Hello, my name is Teresa Cruz. I'm the director of the National Center for Medical Rehabilitation Research at NIH. And today I'm going to talk to you about NIH's support for assistive technology development. I want to thank the conference organizers for the invitation to address you today. So I have no financial interest to disclose. The second half of the presentation, I will be expressing opinions that are mine and not necessarily those of the NIH. So to start off, I'll talk about who is NIH, what is NCMRR, what kind of research do we support, and then I'll get into some opportunities and gaps in assistive technology development that I see. So the National Institutes of Health is the largest funder of biomedical and behavioral research in the world. Our mission is to seek fundamental knowledge about the nature and behavior of living systems and to apply that knowledge to enhance health, lengthen life, and reduce illness and disability. We are organized into 27 separate institutes and centers, plus the Office of the Director. Each institute or center has its own budget and its own mission, and many of them support device development for people with disabilities. It's important to know that NIH funds research across the translational spectrum. The majority of our research support is in basic science, but the goal is always translation through animal models and then into clinical trials and clinical studies. When we're thinking about the development of devices and the development of assistive technology, we really have a goal of getting the devices into the hands of the people who need them. So it's not sufficient that we stay in the lab, that we develop cool things that sit on shelves. So we really need to be thinking about the clinical use cases and then even beyond into implementation and dissemination research. So by way of background, NIH's budget, about 80% of it goes to fund extramural researchers. So people such as yourselves who are doing academic work in universities and hospitals across the country and across the world. About 10% of our budget goes to an intramural research community. We have a clinical center in the Bethesda campus. There are intramural research labs and scientists in several spots across the country. We also do things like identify research gaps, train new researchers, and host workshops to highlight areas of need, participate in meetings like this. Some things that NIH doesn't do, we don't tell clinicians how to care for their patients. We don't tell the FDA what drugs or devices they should approve. We don't tell CMS how much a treatment should cost or what they should cover. Our job is to provide the research by which other people can make those policy decisions. So as I started out by saying, I'm the director of the National Center for Medical Rehabilitation Research, and our mission is to foster development of scientific knowledge to enhance health, productivity, independence, and quality of life for people with disabilities. We are not one of those 27 separate institutes or centers that I mentioned. We live within the Eunice Kennedy Shriver National Institute of Child Health and Human Development. So if you're looking for the rehab center, you have to look inside NICHD, and we do not limit ourselves to only child or pediatric rehabilitation. We address the lifespan. And we have currently 4 program officers who support 6 different programs. But NIH is much broader than NCMRR in our support of rehabilitation. We have a coordinating committee that has representation, 21 other institutes and centers, and many of them will support device development, assistive technology related to rehabilitation or the needs of people with disabilities. And I've listed a handful of them here, but as I said, there are many others. If you are having problems figuring out where your research fits at NIH and it's rehabilitation related, please feel free to start with NCMRR and we will hand you off to our colleagues at other institutes if the fit is better there. So in general, it's been a very good time to be doing rehabilitation or assistive technology work at NIH. We've seen steady increases in both of those categories over the last 5 years. from about 500 million to closer to 750 million from 2015 through 2019 in rehabilitation. And then a subset of that is assistive technology. So when we talk about medical devices for people with disabilities, it's important to understand why we're doing this. We are trying to increase their access to enable participation. So starting with what the person with the disability wants to do, and then developing the technology to help them do that. We are trying to enhance their function, and more we're thinking about how we extend treatment. And the devices that are used for these different purposes may very well be different. So there's lots of different types of disability. So there are lots of different types of assistive technologies. My group typically focuses on things like mobility. So that would include wheelchairs and exoskeletons, also prosthetics, upper and lower limb. There is a huge portion of work around sensory restoration. I have an example of a cochlear implant, as well as retinal prostheses from Second Sight on this slide. But of course, there are others. Neuromodulation used in combination with other types of exercise or therapy. I think we're seeing more of that, both invasive and non-invasive. And I have an example of an OPG from Medtronic here. Communication aids is a huge area. We're seeing a push towards robotic assistance as we have a care partner crunch. Can we provide more robotic assistance to people at home? And then, of course, with the pandemic, a huge need for telerehabilitation and delivery of care at home instead of in an inpatient hospital, which may now be full of recovering COVID patients, people not wanting to go into outpatient clinics for fear of transmission. So there's a huge increase in the telerehab field. So earlier I talked about the importance of the translational pipeline, and I just wanted to give you a couple of examples of where basic research funded by NIH resulted in a product. So here's an example of COAP, which is a spin out of the former Rehabilitation Institute of Chicago, now the Shirley Ryan Ability Lab, that combines both advances in hardware and software for better controlled prosthetic arms. We also have a company called Flint Rehabilitation in California, which has spun out of UC Irvine's robotics lab to develop products where people can purchase these for the cost of about a smartphone to do rehabilitation at home, generally following stroke. So here's a couple of examples where we were able to move the technologies from the research lab and the bench into a commercial product. And there are others, but having that end use case in mind at the beginning, I think is very helpful. I just wanted to leave you with a couple resources as you may be thinking about how your work may relate to NIH funding. We have 6 research infrastructure sites in our network. I encourage you to look at their website, ncmrr.org, where they provide links to the individual sites and describe their particular expertise and their resources. So they have expertise, you can call them up and get a consultation. They provide webinars and classes, they provide sabbaticals, and they also provide pilot funding to help you advance an idea. So 2 of them focus on wearables and sensors to both understand movement and functional abilities of people with disabilities. We have a dissemination and implementation learning health systems resource. We have one focused on pediatric rehabilitation, one on neuromodulation, and one on regenerative rehabilitation. And this is a good example of collaboration and co-funding of several NIH institutes to support these. And then I'd just like you to know about our NIH report and reporter websites. They have been updated recently, but if you're not sure where to go at NIH, the matchmaker function is a really great way to put in your aims, put in your abstract, put in your keywords and see where there is funding at NIH, what study sections, which program officers to talk to, et cetera. So switching gears a little bit about kind of who NIH is and what we do, talking about research opportunities for the future. So I would propose a framework for everyone's consideration here, and there are others, I'm sure, that focus the center of the discussion of assistive technologies on the user, their needs and preferences at the center of all that. You can't focus on the fit or the control or the power without first understanding what the user needs are and what the user preferences are. All these other things are important and we need to advance them, certainly, but really including the person with a disability in the research from the beginning is key. And I just love this slide from our small business colleagues that says the number one reason that biotech startups fail is because you're building something that nobody wants. So then I think that really addresses the, making sure we understand who the consumer is. So some thoughts for the future, starting with the idea of inclusion and universal design in everything that we do. So not just the idea that we are developing assistive technology for a specific purpose, but keep the idea that abilities vary widely for all types of use cases. 10% of people have cognitive difficulties, 14% of people have mobility difficulties, 5% of people have hearing loss, another 5% have low vision or blindness. So abilities vary widely, and we need to account for that at the beginning. I've talked about the importance of figuring out what matters to the person. We've gotten quite a bit of feedback at NIH that we aren't measuring things that the person cares about, and that's pretty humbling. And with that, I would also contend that people have multiple identities. So we should not assume that we know what matters most to any individual person. Coming from an engineering perspective, I've come to realize that we need to make advances in hardware and software and control algorithms and power and all of that. But that's not going to be sufficient to address the needs of people with disabilities. That the other human factors and the behavioral portions need to be considered as much as the technologically focused needs. I think we're going to need partnerships. This workshop is an excellent example of that. There's work going on in industry, which I'm sure is going to be focused on in this workshop, that is beyond what's going on in some research labs. Government and funders can't do everything. We need help from nonprofits and non-government organizations, particularly when we're addressing access of these technologies, which we want to get into the hands of people. So I don't think this is a topic that can be or should be addressed by any one of those organizations, but partnerships between them are necessary. This is kind of a pet peeve of mine, but words matter. So the differences between assistive technology versus rehabilitation technology, and understanding that a device that is meant to train someone in a rehabilitation capacity, and then afterwards a person will have a higher level of function, is going to interact with the biology of the person differently than a device that's designed to replace function and be used permanently. I wear contact lenses every day, and I don't think that, after wearing them for a year, then I'll have better vision. But we seem to sometimes apply that type of thinking to assistive technologies and mix them with rehabilitation. So clearly defining, where your technology fits. And then, the big one at the end here is the rehab community has to move towards open source towards data sharing, towards common data elements. The biggest impediment that we have is small, underpowered studies. And if we want to tap into, this promise of precision rehabilitation, this promise of artificial intelligence and machine learning, we're going to need bigger data sets. And we only get that by open source and sharing and common data elements. So I think the field needs to be thinking about how it can work together to move into a new realm. All that said, I think the time is ripe. There's huge demand for better technologies for people with disabilities. I think we know a lot more about the science of behavior change and technology, broadband. The advancements there make it a time when we can truly advance the field. These are some research questions or considerations that you can have while you're putting together your projects. We've talked a lot about the consumer and the person who's using your device, but we haven't really talked about the disparities in access, health disparities related to underrepresented minorities, differences in age and demographics, SES, rural versus urban, and access to broadband, et cetera. So considerations for who you are building the technologies for. We talked about all the different types of disabilities, and really we didn't talk about all of them. They're quite varied. So understanding what it is that you're trying to deliver with your technology, and there are a few examples here. And then, as we're moving care into the home, as inpatient rehab stays are shortened, as in the pandemic, when people don't want to go to outpatient or they are unable to go to outpatient rehab, and we move into a more at-home or community or tele-rehab based environment or delivery of care, how are we going to do that? And I've listed a few considerations here. So I'd just like to wrap up and say thank you for the kind invitation. I look forward to watching the rest of the presentations from my federal colleagues. Thank you so much.